attempted this. It didn't succeed. The Jubilee administration attempted this, it didn't succeed. And because of the previous attempts, this time round, we will succeed because we can learn from the other two attempts what were the administrative, legal, and even procedural constraints that made the other attempts not to succeed. So we are very sure that Taifa Care will work. Universal health care for everyone will be the institution of our country. KNH is forms a very, very important part of the history of Kenya. We appreciate the leading role that this hospital continues to play in offering healthcare and referral healthcare services to the people of Kenya from across the country. Over 100 years later, the hospital is facing a number of challenges, but I want to commend the leadership of the hospital and all the stakeholders who have worked so hard to make sure that this hospital remains what it should be, what it has always been, and that is the leading healthcare provider in the public sector for our country. This morning, I decided to come and spend some time here, and I did so because where the Kenya Kwanza government has a number of areas that we would want to see transformation in our country. Some of the areas for transformation are in the economic sector, where we are transforming a number of value chains. But one of the pillars and one of the key deliverable areas is healthcare. And there is a pillar for the actualization of universal health coverage and making healthcare accessible to all the people of Kenya. And that's why there were some changes that have been made. We have changed the law, we have changed the institutional arrangements for delivery, and we introduced Taifa Care, which now is housed under the Social Health Authority, SHA. And therefore, I was asked by His Excellency the President to come and assess the impact and the experience that patients and health workers are having under the new Universal Health Coverage Program under Taifa Care. I have been able to talk to patients. I've also been briefed by the leadership of the hospital and the health workers here. I've been able at least to go to the trauma center where we've patients who are on emergency care. I've also been to the maternity and also other critical care patients who have medical issues like heart issues, kidney issues, and so forth and so forth. And finally, I've been able to see the now almost ready East Africa Kidney Institute, which is more or less His Excellency the President will be commissioning shortly once some of the outstanding issues are done. Therefore, it is the intention of government to make sure that every Kenyan accesses medical services, that every Kenyan accesses healthcare services. The numbers are picking up, but they are under the Social Health Authority so that they can be beneficiaries of Taifa Care. It has a better package because from the impact stories that we have heard from especially critical patients of critical illnesses, those who have undergone kidney transplants and heart-related diseases treatment. This Taifa Care offers a better package, especially for post-transplant treatment cases. In many of the cases, I have been informed by the patients themselves that the process of getting services is fast, outpatient, and even inpatient. And even the approvals for the bills is taking a very good record time. We still have 1 or 2 administrative procedural hiccups, some of it related to documentation, some of it related to technology, and we are consistently resolving those hiccups to make sure that Taifa Care delivers universal health coverage for all the people of Kenya. This is not the first time we are trying this. The NAC administration attempted this. It didn't succeed. The Jubilee administration attempted this. It didn't succeed. And because of the previous attempts, this time round, we will succeed because we can learn from the other 2 attempts what were the administrative, legal, and even procedural constraints that made the other attempts not to succeed. So we are very sure that Taifa Care will work. Universal health care for everyone will work this time round. And I want to assure the people of Kenya that we will continue with this exercise of impact assessment, impact monitoring, not just at KNH. We may have started at KNH today, but we are going to other points of service delivery, level 4 hospitals, level 3 hospitals, level 2 hospitals, because there are, again, challenges that are at other levels of facilities, which are in a different level than KNH. And again, we are addressing those ones, including the hospitals that are under county governments. The national government will work in collaboration with county governments to address those bottlenecks around, especially referrals in level 2 and 3 hospitals, and also around diagnostic capacity of those lower level hospitals. So we are working very hard to make sure that this program succeeds. We will leave no efforts until this program is on its feet. Those who have provided us with feedback on where the problems are, we take that feedback positively, and we are working to unlock the bottlenecks that have already been identified. The claims right now, many of them have been paid for under SHA, except where there are small administrative issues. I think that bit is okay. But the facilities, many facilities are still having a bit of issues because of the historical debt accumulated under the NHF. That historical debt, the government is also trying to offset incrementally, because again, the resources may not be enough for us to do everything at once. So we are committed to deliver this program. I want to thank the leadership of the Ministry of Health, my colleague, Cabinet Secretary Deborah, who is here, Dr. Deborah Barasa, the PSs in that ministry, Dr. Harry Mutahi is here for medical services, the PS for professional standards and public health, Mary Modoni is also here, and that team, together with other senior officials, including the Director General for Medical Services, who is also here with us, Dr. Amoth. The team there and many other colleagues whom I don't have time to mention are doing a wonderful job. They have the support of the President, the support of the government, the support of other colleagues in government, because health interfaces with so many other things. I also want, before maybe I finish, point out in a very, very profound way the contribution of the University of Nairobi, the School of Health Sciences, which has all this time partnered with KNH as part of the training program for our healthcare workers. The University of Nairobi remains at the center of the delivery of the health services in this institution. We appreciate that for us to fix health service delivery issues, we must also support the University of Nairobi. We must support the School of Health Sciences at the University of Nairobi, and so that the entire ecosystem of healthcare service delivery is seamless and is taken care of. So we are working very closely, all of us as a team, including county governments, because we believe, and this is where it's important, for the Taifa Care program to succeed, for UHC to succeed, we believe as government that it will be important that the human resource component goes along with the brick and mortar projects and programs that we are putting in place. Very, very finally, the East Africa Kidney Institute, which I have said is ready, is a center of excellence for renal care for this region. So it's going to be an international standard facility for renal care. It's going to offer not just dialysis services, but also kidney transplant services, cutting down the expenses, the logistical nightmares of many, many patients from Kenya who have had to travel out of this country for kidney transplants and other related services. So it's going to be a one-stop shop for all renal treatment related healthcare services. And in a few weeks' time, it will be commissioned. Actually, I have seen the equipment is there, everything is there. It's just a few things, including certain regulatory arrangements that needs to be placed, which we will finish within a month, at most 2 months, so that by end of March, the patients can start getting treatment. So that is what has brought us here. I mainly came to listen from those in the SHA ecosystem, the patients, the health workers, from the point where the service is being delivered. Because sometimes when we listen to people giving their experiences, and some of these people have not been to any hospital, they have not had any patient, they have taken there, but when they talk, sometimes you are tempted to believe them. So the only way to counter-check some of the feedback is for us to physically come here and talk to the people from the points of service delivery. Ni hayo tu kwa sasa, na washukuru sana. Na mimi naomba, kwa sababu watu wa hospitali ikifika saa 7 wagonjwa watu watakuja kuona wapendo wao, and there will be many people walking in. I will allow only one question from whoever shoots first, and then we can continue with this discussion. In any case, my colleagues here, CS, Barasa, the PSs, and the entire MOH fraternity is always available. You can always talk to them. They will always talk to you. But for the purposes of my visit here, I will allow one question, and then we leave it at there. Thank you very much.
Thank you, Deputy President Professor Kindiki. My name is Mary Mwoki from Citizen TV. My question is on the financing of SHA, especially for the primary health care fund. Going by the data released by the authority last week about the disbursement, a very small portion went to primary health care fund, yet this is the place where a lot of health seekers begin, and it's leading to a lot of out-of-pocket expenses. How is the government intending to handle that? Thank you.
It is true that primary health care is at the core and is quite consequential in terms of achieving success for this program. The government is seized of that fact, but at the moment, if you aggregate the entire input, budgetary input into primary care, I hope you are also including the expenses the government is making or incurring with regard to community health promoters, CHPs, which consume around 2.5 billion a year as national government contribution, because the CHPs form part of primary health care medical ecosystem. Other than that, it is true, even the financing, because the total, if you add the 2.5 billion budget for CHPs and the other budget for other primary health care services, the total budget is 6.2 billion, according to the data that have been given. And that amount of money, therefore, may not be adequate, and therefore we are looking at ways of, if, for example, through the supplementary budget, we can, again, resources permitting, adjust a little bit, a bit of resources. But as you know, early this year, the revenue-raising instrument that was proposed did not materialize, the finance bill of 2024. And that affected funding of sectors across government. The 2 levels of government, the 3 arms of government were affected. But nevertheless, even with the shortfall, we will go out of our way to continually and continuously adjust our budgets to make sure that primary health care is not left out, because it is very critical for us to get it right from that point of view. Asanteni sana, Mungu awabariki. Kwaherini.
Asante sana Mheshimiwa Naibu wa Rais. Kwa sasa tutakuruhusu uweze kuondoka kwa hiari, nikiwakaribisha wanakwaya muweze kumpakulia kibao kimoja. Karibuni.